Good evening, everyone. Just waiting for a few people to join the call. My name's Nigel Denning. I'm a counselling psychologist based in Melbourne. I'm also the director of integrative attachment therapy, an organisation that I've co-founded with my colleagues, Dr. David Elliott and Dr. Trail Dowie. And this is an organisation that is really committed to understanding and working with attachment disturbance in adults. My personal background, I've got a pretty broad background in working with family violence, trauma, institutional abuse. I've previously been family violence coordinator for Relationships Australia. I've been the clinical director of SANE Australia, a lived experience organisation, the deputy president of In Good Faith, an organisation that was committed to working with survivors of institutional abuse during the Royal Commission period in Australia. And I've trained extensively with attachment work. I was first introduced to the AAI in a 12-month training that I did with Dan Siegel quite some years ago, when he was developing interpersonal neurobiology as a model modality. The AAI was something that was talked about quite a lot. And then about 15 years ago, I met Daniel P. Brown, who was a Harvard professor who had developed an attachment repair model utilising the AAI. So when the opportunity came, I decided to do AAI training, which is a pretty rigorous training. It's a 2-week immersion initially, and then 2 years of assessment. And you need to in a period of 2 years, you need to get an 80% accuracy in your assessment of a number of transcripts. So we get a fairly detailed understanding of what the AAI is, how it works, and how to administer it. What I'm talking about today is really just an overview of the AAI. I think the model of the AAI and the training of it for the AAI predominantly oriented towards researchers. So what we've been doing for quite a few years now is trying to really utilise it for therapists, so that we can get a working knowledge of people's attachment patterns, and then use material from the AAI to plan our treatment. So next slide. What is attachment? It's quite a popular term at the moment. It's one of Google's most searched terms, in fact. And I've been working for a number of years, as I said, with Dan Brown, with David Elliott. Did a lot of work with Jock Gordon in setting up the attachment project as well in the early days. And attachment is essentially a survival-based bond between the infant and caregiver. It's very much an adaptive strategy. Human beings are born without a lot of survival capacity. If you think about a little baby, there's not much that they can do other than attract the interest of an adult, and they completely depend on an adult for survival. So attachment becomes a very, very fundamental way for our species to pass on its genes, essentially. The infant needs to have an adult attend to it in such a way that it can survive and develop structures in their brain to make them function independently. These attachment patterns are established between 8 months and 20 months of age. So they're happening at an extraordinarily young age, and what we would describe there is a precognitive stage of development. So what we mean by that is that attachment occurs before we have language, before we have structured thought, before we have the ability to really um, understand ourselves or reflect on ourselves or communicate. So it's a very, very instinctive um, model of development, and a lot of it occurs in the limbic regions of the brain. And this is a part of the brain that is really about 200 million years old in terms of its evolutionary history. And the structures of the limbic brain are shared with most higher order grouping animals. And there's a lot more similarity in the limbic brains of uh, other species than there is difference. So this part of the brain is really fundamental for the attachment process and the modulation of affect. What affect is the felt qualities of what we later describe as emotions in humans. They provide a layer of regulation, which adds to the infant's capacity to downregulate hyperarousal without going into hypoarousal. So, as many of you would be familiar with, the features of trauma work, and the fact that human beings are born like all animals. We're born onto the planet with a biological drive to survive. This is an upregulated hyperarousal response. The adrenocortical system is all about survival. And the only option available other than hyperarousal is hypoarousal, which is shutting down, flattening, turning off. And so without a caregiver, without an adult to provide adequate attuned care, this is what happens to a baby. They stay in hyper or they move into hypoarousal. Next slide, thanks. What we find, and the history of attachment work, of course, dates back to the work of John Bowlby. Bowlby started to hypothesize about why, after the Second World War, after a whole bunch of children had been sent away from bombing zones in Britain into residence in the country, why, when Victory in Europe Day occurred, VE Day, and all the children were returned to their families, the idea was that there'd be these happy reunions and there'd be this kind of rebonding and reformation of family. What Bowlby found was that this wasn't necessarily the case. That a lot of the returning children had really developed some pretty nasty antisocial orientations. This started off the program, and so Mary Ainsworth then came along and started to systematise Bowlby's work, and she developed a program called the Strange Situation. And what we find over time is that there's about a 75% correspondence between how an infant's attachment system is measured and assessed compared to their parents. So parents with poor attachment or attachment disturbance have a 75% chance of creating children with similar issues. So what we're talking about here is attachment disturbance becomes an intergenerational problem. Skills, abilities, capacities, patterns are passed down from parent to children. And in the West, we're looking at almost half the adult population have insecure attachment patterns. It's really important to recognize that we're talking about patterns here rather than personality structures, rather than something fixed and rigid. We're talking about something that patterns up as a survival response to environment. But if you think about, everyone almost half of them are going to express some kind of attachment disturbance. And this corresponds with why perhaps we have such huge divorce rates. That when couples get together and create relationship and stress inevitably enters, how we deal with that stress, how we anticipate the pattern of the relationship, the outcome of relationship is all influenced by what Bowlby described as our internal working model. And our internal working model is a biologically based, affect-based, predictive response to environment. And what we see in a lot of the research is that attachment disturbance patterns link to adult disorders, psychological disorders such as depression, anxiety, and personality disorders. And the work of Anthony Bateman and Peter Fonagy at the Anna Freud Centre in London is all about assessing and reforming the way in which attachment has affected people with antisocial personality disorder and borderline personality disorder, how attachment patterns and the reformation of those patterns can help people emerge or heal or reconstruct these personality problems. Next slide. So the very first measurement of attachment was Mary Ainsworth's strange situation. People may be familiar with it. And this is where, a very structured way of observing a child and mother's interaction, usually mother, could be any parent, it's not a gender-based thing by definition. But the strange situation measures the way in which an infant responds to a parent leaving its proximity and returning. So what we see in that is children either have a secure response, in which case they can regulate while the parent's there, they can soothe themselves when the parent's gone, and they return. When the parent returns, they have a kind of positive response. Or alternately, the child has a distressed response, or the child withdraws and doesn't seem to recognise the absence of the parent. This is a really interesting kind of lineage tradition in attachment work. So it's one theorist's work is developed by the next theorist's work. So John Bowlby worked with Mary Ainsworth for a number of years and helped her to develop her laboratory-based model of measurement, and she in turn helped him demonstrate some proofs of his theory. Then Mary Ainsworth worked with Mary Main, who by training was a linguist, and Mary Main was really interested not so much in childhood patterns, but adult patterns of attachment. Mary Main really wanted to understand how we can measure attachment in adults through language, through their vocalization. And Mary Ainsworth was in attendance at Mary Main's first trainings in the adult attachment interview. Mary Main worked with Carol George, who's developed an alternative model, the adult attachment projective picture system, which a number of my colleagues use and use with great efficacy. It's a very different model of working, and it works a little bit more like the thematic application test, the TAT, where images are shown and people are then asked to respond to those images in order to generate something about their attachment style. What it does is it amplifies and helps us understand the affective regulation, but not so much the organisation of mind, which is really a key feature of the AAI. Patricia Crittenden also worked with Mary Main for a period and developed the dynamic maturation model, which is a lot more nuanced version than the AAI in terms of its outcome, and identifies a lot more patterning in attachment, a lot more diversity, which makes it in some ways a little more difficult to utilise. But again, I've got colleagues that utilise this model really well and find it very, very useful. Then, of course, we've got Peter Fonagy developed the reflective functioning scale. This is an extension of one of the elements of the adult attachment interview, which is Mary Main's view of metacognitive monitoring, the ability of someone to in process of exploring their mind and talking about attachment experience, exploring that in their mind and body, for them to be able to reflect on in situ how their mind's working, which is something that doesn't occur when people have quite pronounced attachment disturbance. So Peter Fonagy extended the metacognitive monitoring into a more detailed reflective functioning scale. I've done training in that particular model as well. The ECR, the various versions of the ECR is more of a tick and flick tool. Can be quite useful. A friend of mine, John Gordon, who set up the attachment project, has collected a couple of million responses to the ECR. So really developing quite a detailed map across the world of people's attachment patterns. It's a very kind of rudimentary scale. It doesn't have a lot of positive correspondence to the other more detailed treatment tools or assessment tools, I should say. But it's for a therapist, on the fly, it gives you at least some kind of ballpark understanding of someone's attachment pattern. The AAI is the most detailed of all of the assessment tools and gives, as I said before, most information about the organisation of the mind. You really see this. The more transcripts that you read, the more you kind of start to see the nuance and detail in what's working in people's organisation and what's not working. As I said earlier, it's a 2-year training. It's quite a demanding training. So 2 weeks of immersion. We work long days across those 2 weeks because we were constantly scoring and learning the scoring systems. And then for the next 2 years, we would receive quarterly a stack of about 10 transcripts, which ran from somewhere between 15 and 50 pages each, and we'd have to score them to an 80% accuracy. So quite a grueling kind of process, and that was really for a research outcome. So in order to publish and to provide research around the AAI, you need to complete that kind of training. But if you're not interested in the research side of things, if you're really wanting to get a good clinical picture of your client's attachment style, the AAI can be used quite well on the ground as an assessment tool that helps for our treatment planning, which is how I've been using it for a number of years now, and how we've been working with several hundred students that we've trained in this model. Next slide. So the purpose of the AAI is really to shock or to surprise the mind of the client into revealing its unconscious organisation, its patterns, its instinctive patterns. So if you remember, the internal working model that was proposed by Bowlby is really about body-based, instinctive, intuitive responses to expectation of relationship. And so the AAI is really designed to try and really excavate that, and really generate detail around how this person's body has learned to anticipate relationship, and then that has filtered into the way their mind is organised and the way they conduct themselves in relationship, the way they respond to relationship. So we ask for a detailed description of childhood experiences. And what we do there is we elicit patterns in the language of the individual, patterns of coherence, narrative consistency and productivity. So Hess, Eric Hess, Mary Main's husband, sadly Mary Main passed away a year or so ago, but they co-developed a lot of this material for the AAI and the AAI tool. And Hess describes the AAI as an interview-based method of classifying a parent's state of mind with respect to attachment. So pretty straightforward, pretty focused on the goals. And as I've said, it's a research-based tool. And we've adapted it through its clinical utility through the 3 pillars model, what we call the ideal parent figure protocol, that was developed by Drs. Daniel P. Brown and David Elliott as part of a supervision group and a research project attached to Harvard Medical School over a number of years. And their use of the AAI varies from very, very detailed kind of pre and post assessment to more clinically oriented mapping of the immediate needs of the client in order to develop the therapeutic approach. Next, please. So importantly, the administration of the AAI. This could be a little bit tricky if you're going to do an AAI with a client with whom you already have a working relationship, have a therapeutic relationship, because the way that this is administered is pretty defined. What we're trying to do is create a container where we can ask a structured 20-question interview of a client. And for therapists, it can be very difficult to restrain some of the conjectural, the amplifying questions, the empathetic attunement, because we actually don't want to enter during the administration of the AAI that therapeutic space with the client. What we want to do is really take the time, and it can be 45 to 90 minutes, take the time to really get a response from the client that helps us map their attachment patterns. So it's very, very specific, very contained. We need to be very, very clear. And so what I do with clients that I've seen for a while is explain that in this session, when we do this interview next week or whenever we're going to do it, that it's going to feel quite different. When I come into the therapy room with you, we're not going to do therapy in this process. I'm going to ask some difficult questions. And certainly after we've completed the administration, we can talk about it. But in the time that we're working through, I'm going to need to follow through on the questions. So that in the 3 pillars approach, that's what we would call a collaborative approach to working with the client. So the interviewer follows a structure of the 20 questions. In the manual for the AAI administration, and this is available online. This is a public domain document, so you can all find it, have access to it and read through it. There are 2 versions generally. One is the really kind of pared back, just the 20 questions, and the other version of the AAI has some expansion questions, which we're allowed to ask just to get a little bit more detail from our client. But as I said, no therapeutic conjecture, no therapeutic support. So it can be difficult then for both therapists and client alike. We audio record the interview, and we then transcribe that recording. And then we can do that using transcription software. We've got a transcription service that we use. I know Dan Brown used to like doing them himself, so extraordinary amount of time and effort goes in. If any of you have tried transcribing a 60-minute interview, what's important when we transcribe is that all of the lines are numbered and that all of the periods of silence, anything that kind of, any non-verbal kind of cues, sounds, that kind of stuff, that's all recorded. And in the transcription, we'll have parentheses where, 20-second delay or 60-second delay. And that's really important as we start to kind of learn to map the way in which a mind works when we're bringing our client's mind into a relationship with their underlying attachment system. So getting that really kind of clear in the transcript becomes critical. Next, please. what it renders when we score, and I won't go through a lot of detail about scoring. That's quite a detailed kind of process in itself. But the scoring renders 5 separate classifications. So we get secure, um, which represents possibly half the population. We have dismissing, which maps across to Mary Ainsworth's anxious avoidant classification in children. One of the confusions in the whole attachment research world is that the nomenclature for adults is different to that as children, that of children. So Ainsworth work talks about avoidant attachment, anxious avoidant attachment. The adult talks about dismissing, which you could map across as a hypoarousal response. So dismissing tends to be a flattening, a disconnecting, a devaluing, just a kind of repressing kind of feature. It can also lead to dissociative features as well, dismissing. And preoccupied is what in the Ainsworth model, anxious attachment. Mary Main describes the preoccupied mind as a mind that at the dining table, the hand reaches out for the glass of water in front of it, but can never quite get there. Is always involved in reaching, not meeting, returning. The preoccupied is forever trying to seek completion in the pursuit of the other without ever realizing it. And so the preoccupied mind we could describe as a hyper-aroused mind. And these features come about as a relationship between infant and caregiver. So what we're looking for in the secure transcript is evidence that the adult was attuned, and it doesn't matter who the adult is. It can be a mother, a father, grandparent. It doesn't actually necessarily matter as long as that person is consistently available to the child and shows reasonable levels of attunement to the specific needs of that child. That creates security. The dismissing child is the one who cries in the crib, cries in the cot, but the adults don't attune to it adequately. And eventually the child just gives up. This was a feature, people would be familiar with controlled crying. And it's used in a kind of a greatly kind of reviewed form these days. But controlled crying was very big, 30 years ago. And the idea was that if a child wasn't settling for the first months, even years of its life, you'd go to a maternal care centre. The child would stay there overnight. Mum and dad would be sent off. And the child would be left to cry. Someone would come and look after it after a few seconds. Then you'd elongate the time between. And the idea was eventually that that child would learn to self-soothe because it would be learning independent regulation. Research was done on children coming through that process, and some clever researcher worked out to swab the saliva in the mouths of those children. So a non-intrusive way of assessing. And what they found is that these quiet children often had really heightened levels of cortisol. So rather than self-soothing, they were going into this anxious avoidant stage. They were shutting down, they were switching off, which obviously has, massive repercussions potentially their development. So dismissing, preoccupied. And then the fourth classification, which wasn't present initially in Ainsworth's work, but became a feature of children, generally children that came from environments of neglect or abuse. So what we have in a cannot classify, and it's called cannot classify in the AAI system, because the child is moving between dismissing and preoccupied, or the adult mind is moving between dismissing and preoccupied all the time. There's nothing stable. And this is a feature of an infant who cannot anticipate and predict whether they will be cared for or not. Inconsistent care from the primary caregiver. Sometimes they're available, sometimes they're not. Can really factor into this cannot classify or disorganized attachment style. This attachment style maps very, very clearly onto adult psychological presentations such as borderline personality disorder. There's a 100% correspondence between disorganized attachment and borderline. What that suggests to us is that if we can understand how these structures come about, then we can design therapeutic approaches to rectify them. And my colleagues and I have had quite good success in working with very complex cases that hadn't responded to other types of therapy. The fifth part of the classification system is unresolved for trauma or grief. And this is an interesting feature that it's really, really clear in AAI transcripts. The cannot classify or disorganize mind is consistent across the transcript, that it moves between dismissing and preoccupied features, moves between hyper and hypoarousal throughout the whole of the transcript. When we're looking at an unresolved for trauma or grief, what happens is you have a consistent pattern, and that could be consistently secure, consistently dismissing, consistently preoccupied, but then you come to an event. You come to the retrieval of a loss or a trauma, and the mind suddenly disorganizes, and it becomes quite vague or quite disrupted. So that tells us that there's a probability that unresolved grief or trauma is a significant feature of the of this particular person's presentation. And so you can have a unresolved for trauma or grief as a parallel to any of the other secure, dismissing, or preoccupied. It's very hard to distinguish unresolved in disorganized because the features of a disorganized, as I said, are very, very similar to trauma or grief. It's just that rather than being event specific, it's consistent across the whole of the transcript. Next. The expanded classification system, and this is where there's strengths in really learning how to score, how to administer and score the AAI, because what we can see is that rather than there just being unitary features of each attachment style, that they are multi-layered. So dismissing, which is the D, actually has 4 classifications, which is DS1, DS2, and then DS3 splits into 2, A and B. And they just give us a lot more detail about the nature, the way in which this kind of hypoarousal quality manifests in the coping strategies of the adult. The D1 has a manuscript would be as little as 10 pages. Can you remember what your relationship with your mother was like? Oh, it's good. Can you tell me a bit more? No, it's just fine. That's it. And you can ask expanding questions, and that's all you'll get. The D2 is more derogatory. I'm tough. I never needed anyone. That's for weak people. You get these qualities. There's a kind of more of an angry kind of quality. And the D3, A and B, are more typical. They're not as severe as the first 2, but consistently through the transcript, what we find is a devaluing of attachment. Then we get into the Fs, and there are 5 Fs, and the F represents secure attachment. But what you see here is secure attachment with features of dismissing and features of preoccupation. There's a prototypical secure, which is the F3, and that's really a fresh, reflective, organised mind that is consistent and able to retrieve positive and negative memories and talk about them in a very present manner. The F1, 2 have dismissing qualities, but are essentially secure. The F4 and 5 have preoccupied qualities, but again, fundamentally secure. Then we go into three levels of preoccupation. The E1, which is passive, which is a typical, kind of prototypical preoccupied style. Then there's an angry preoccupied style, and very rare, the preoccupied fearful style. Tends to blur more into the cannot classify. But we see in these features, the E1, 2, and 3 are hyper-arousal oriented ways of coping, and what you see in your clients are people who are forever seeking and going after partners and can't give up the past, want to change, but see it always as resident in some kind of external relational change. It's a it's a it's a real hell world to be endlessly chasing and never receiving. Good news is that all of these things, once identified, we can kind of look at treatment pattern or treatment plans that can correct. Next, please. So when we look at the AAI, it's basically it's a multiple reading. So what you have in front of you, once the interview, once you've got your transcription, you've got something between 12 and 50 pages, and you've got it with all of the lines numbered throughout the transcript, because you're going to be making a lot of notes as you go along. And you do the initial read through just to get the feel of the transcript. And one of the kind of key indicators is length of the transcript. A dismissing attachment transcript will be short, preoccupied will largely be long, and the secure will be somewhere in between. You do an initial read through, and then the next read through, what you're looking for are scales for inferred experiences with parents. And these are structured scales that we can teach you how to understand, how to score them, how to identify them. And you write these, and we have a kind of color marking way of identifying the different features, and we write those down the left column of the transcript. And then we do the next read through where we're looking for scales for patterned or organized states of mind. Again, we do that as a marking on the right column as we work through. So here we've already done three read throughs of a single transcript. Then we're looking for scales for unresolved disorganized states of mind. And then finally, we go to the adult attachment classification system, which is part of the training manual, but it also is available as a description of each of the attachment styles. So we've done 4 read-throughs in order to adequately assess a transcript. So it's quite time-consuming to mark, but the more used to it you get, the quicker that process comes, and you start to train yourself in linguistically what to look for, what features of the transcript, what it's saying, and it becomes increasingly easy to score. It certainly is a different if what you're trying to do is publish your results or really do this as a research tool. It's a different kind of quality, but we can get a pretty good understanding of the organisation of mind through reading through in this manner. Next, please. The first questions, as mentioned, are about are designed to engage the subconscious, and really critical for designing our treatment is the next stage. What we're asking for from the person we're interviewing are 5 adjectives. Initially, 5 adjectives that describe the quality of the relationship between you and your mother when you were 5 years of age. So in order to elicit this, we ask people to relax, take some breaths, go inward. We're not trying to hypnotize people. We're not trying to do anything to manipulate them other than to relax them, to allow their mind to drift back to somewhere between around 5, can be as old as 12. Some people, particularly dismissing people with severe lack of memory, find it difficult to go back that early. So somewhere between 5 and 12. And then we ask adjectives to describe, not to describe your mother, but to describe the quality of the relationship between you. We take those 5 adjectives. Now, that can be difficult, particularly for people with a dismissing or hypoarousal attachment style. So what we would do with them is ask a few extra questions, give them extra time, but getting 3 adjectives. Sometimes we just have to make do with that. Preoccupied will tend to give more than 5 or give a lot of detail. And same with the cannot classify. What we then do, once we've got 5 adjectives that describe the relationship between the mother and the child, we then ask for evidence, episodes, details that help us to understand that adjective. And what you then start to see is, the differences in retrieval. So someone with a dismissing attachment style will say, oh, it was a loving relationship. So can you give me an example of what you mean by loving? Oh, I got home from school and she made me a sandwich. Yeah, and? Yeah, that was it. What else? What else was loving? No, she just really looked after me. What else? I don't remember. Can't tell. Don't know. You might get from someone with a preoccupied attachment style. Tell me about loving. Oh, it was incredible. And we went out one day and she really did this incredible thing where she bought stuff. And then we went to this other, when we were on holidays, that was incredible. And then it just, the information can go all over the place. Yeah, you're getting a little bit of it. We then ask, after we've done adjectives for both the mother and the father, and if there's not 2 parents in their history, we ask if there is an additional attachment figure, like an uncle, auntie, grandparent, that kind of thing, and do the same process with that figure, just so that we have, the balance of 2 adults if possible. And we ask for descriptions of what the parents did when you were sick, injured, or distressed. And this is enough information for us to really form up some pretty solid hypotheses about someone's attachment style. Next, please. So what we then do with the results of the adult attachment interview, is we apply it to a treatment that we've developed from the work of Drs. Elliott and Brown. Dan Brown was one of my most cherished mentors. We had him to Melbourne on many occasions over the last 15 years or so, but sadly he passed away during COVID. So we've developed a lot of this work in conjunction with David Elliott, who was the co-author of the classic book on attachment, published in 2016. And we've developed an online training where we've updated contents of that 2016 book with, the 8 years of research that's occurred since then, lots more kind of clinical understanding, and we've inverted the presentation in that text. And so, what was novel, and what is novel in the treatment, is that we use an imaginal process, not hypnosis, not age regression, but simply the imagination, to create 2 parents. We use the opposite adjectives to those of the biological parent. So there's 2 parents who are ideally suited and who are attuned. What we do is we go through, in our therapeutic sessions, we go through this imaginal process to correct, using the data that we've elicited from the AAI. The inversion that I'm talking about there is that what we saw when talking with David, and really after doing quite a bit of work with clients with the model, is rather than the original orientation was to put the ideal parent figure protocol as the primary pillar, and then metacognition and collaboration as second and third. And what we looked at when we were talking and working through this with David Elliott was that collaboration and metacognition are really kind of modern ways of talking about non-specific factors in therapy. So we'd be familiar with, all the research that tells us that relationship, whatever therapeutic model we're using, It's the relationship that really is the catalyst of change in therapy. We need skill, we need technique, but it's how we deliver it, how we hold it, how we overt our thinking to our clients, how we create the set and setting for our clients. These are the things that really matter. And on the other, that would kind of be contained within the collaborative frame. The second part is metacognition, and that's really what Mary Main is pointing to in the AAI, is helping to understand how a mind is operating. And when we're talking about attachment repair, what we're trying to help people do is see the underlying patterns that form their mind. The internal working model Bowlby pioneered is an instinctive model. It's an intuitive model because it's precognitive. But it's that precognitive structure that informs as someone gets older and more complex and more sophisticated, more language based. It's that early, implicit, body based shaping that often informs how we enter a relationship, what we expect from a relationship, and how we exit relationship, which is, our 56% divorce rate in the West. And I think second marriages have something closer to a 70% divorce rate. So what clearly happens for people is they don't learn about their attachment patterns. Other sort of significant patterns, not all just attachment, but this is a really significant part of working with people. Next, please. So what we offer, and I've got a training coming up on the 4th of April, an online training, which we'll also record, is a way of helping clinicians really get something out of the AAI that can help them understand their client's attachment pattern, understand then how to turn that knowledge into clinical intervention and how to treatment plan. We have a specific model of treatment. It's not the only attachment-based treatment model. So I'm sure people listening into this call, will have other trainings and other wisdoms. We're not saying this is the only way or the best way necessarily, but we have found that this has been a really powerful and profound way of working. So what we're going to do in the AAI short course is really help you understand how to use the AAI as an assessment tool. We'll summarise the core purpose and structure of the AAI, and then we'll identify and differentiate the 5, there's a typo there, the 5 primary classifications, to demonstrate competence in administering and following the structure. So as I was saying before, the importance of really setting this up and working with it well. We identify potential ethical considerations when conducting the AAI, including informed consent, interviewee distress, and the limits of the interpretation. Attachment patterns are patterns. They're not solid personality structures or kind of unchangeable structures. We'll analyse excerpts of the AAI transcript in the training to identify lapses in monitoring, shifts in coherence, and dysregulation. And it just becomes really blatantly obvious when you start looking at how these transcripts look in relation to these features. We'll use the AAI classification to inform preliminary case conceptualization. And then we'll integrate that into clinical observations and history, so we can really start to really develop a solid conceptualization from this data. And then we demonstrate proficiency in summarising the AAA findings in clinical notes, case reports, and discussions. Thank you. And what we're aiming for is to have a world where every adult and every child operates from the 5 conditions of secure attachment: protection, attunement, soothing and reassuring, express delight, and unconditional support, and the encouragement of exploration. Really getting that dopamine going, and switching off the adrenocortical system, the fear-based system that dominates and drives so much of our irrational, destructive behaviour on this planet. Just attachment really is an important way of down-regulating, creating internal coherence, which then leads to relational coherence, which ultimately leads to better worlds. So thank you. Next. So we might just turn the slides off for a moment and just if anyone's got any questions.